For every single patient who sadly dies after a major trauma, there's a statistic that honestly is just heartbreaking. For that one person, there are 3 others left with a significant, often lifelong, functional impairment.
And that ratio, that 3 to 1, is exactly why we're here today. It completely sets the stakes.
Right.
We're not just talking about saving a life, which is paramount, of course. We're talking about saving function, restoring someone's ability to walk, to work, to live independently.
Absolutely. Welcome, everyone, to the Deep Dive. Today, we are jumping into a really critical area of surgery. We're doing a focused interpretation of Chapter 32 from Baily and Love's 28th edition, which is all about extremity trauma.
And this is really for you, the medical student, the junior clinician trying to make sense of this on a busy night shift, or anyone who's just deeply curious. Our mission here isn't to just read the book to you.
No.
We want to synthesize it, pull out the high-yield concepts, and give you a sort of ready reckoner. We're going to use some key anchors and metaphors to make sure these ideas really stick.
And this is a really important point we have to make right up front.
Yeah.
This is our interpretation. It's our way of contextualizing the material to make it more digestible. It is absolutely not a replacement for reading the textbook.
Please read the book. We can't stress that enough. Think of this as your study guide, the conversation you have after the lecture to make sure you really got it.
Exactly. And the core goal of this whole chapter, and really the whole field, is it's simple to say, but so hard to do.
It is. It's to return the injured area to optimal function as quickly and as safely as you possibly can.
And achieving that starts, funnily enough, not with the broken arm or leg, but with the entire patient.
Always.
Okay, so let's unpack that. Life before limb.
Yeah.
It's a phrase we hear all the time, but what does it actually mean when you're standing in a trauma bay with alarms going off?
It means you have to resist the visual temptation.
The gore factor.
Exactly. You see a shattered femur, a bone sticking out, and your instinct is to focus on that. But extremity trauma exists on a spectrum.
Right.
On one end, you've got an isolated injury. Someone falls, breaks their wrist. Straightforward. But on the other end, you have the multi-system trauma patient from a high-speed car crash. And that patient introduces our absolute number 1 rule.
The surgical priority list.
It's the mantra. Every single patient, no matter how bad the limb looks, starts with ATLS. Advanced trauma life support.
The ABCs.
Airway, breathing, circulation. You have to stop massive hemorrhage. You have to make sure they're getting oxygen before you can even think about that broken bone. A patient can bleed out from a ruptured spleen or a pelvic fracture way, way faster than they'll lose a limb.
So picture this. Patient comes in, massive internal bleeding, and a just horribly deformed, shattered tibia. The tibia looks terrifying, but it waits.
That absolutely waits. You have to stabilize them first, get their blood pressure up, get them warm, stop the bleeding you can't see. Only when that patient is physiologically stable can you move on to the secondary survey, which is where the limb finally gets its moment in the spotlight.
It sounds like a real philosophical shift for orthopedics, right? Moving from this ideal of get it fixed perfectly right now to something a lot more pragmatic.
It is, and there's a name for it, Damage Control Orthopedics, or DCO.
Okay.
And it's a critical framework. We now understand that a long, extensive orthopedic surgery like putting a nail down a femur is what we call a second hit to the patient's system.
A second hit. Explain that. How can a surgery to fix a problem cause another problem?
Well, the initial trauma, the car crash, has already kicked off a massive systemic inflammatory response.
The cytokine storm we mentioned.
Exactly. Their body is already in a huge metabolic battle. If you then take them for a 4-hour surgery with more blood loss, more tissue damage, you are essentially giving them a second overwhelming physiological insult. You're pouring fuel on that inflammatory fire.
And that can push them over the edge into things like ARDS or multi-organ failure.
Precisely. So DCO is the strategy to avoid that. It's about doing the bare minimum safely to bridge the gap.
So for that femur fracture,
instead of the definitive nail right away, you might apply an external fixator. It's quick, it's minimally invasive, it stabilizes the bone, controls bleeding, helps with pain, and most importantly, it gets the patient off the table and to the ICU to recover. Then, 24, maybe 48 hours later, when they're stable, you can bring them back for the definitive fix.
that makes perfect sense. But let me push back on that for a second. If you've got a really complex fracture that goes into a joint, doesn't leaving it in an external fixator for 2 days risk stiffness or more scarring? Aren't you compromising the final outcome for the limb?
That is the essential dilemma, and it's a fantastic question.
Mm-hmm.
And the answer is yes, there are risks, pin site infection, stiffness for sure, but if the patient is unstable, if they're cold, acidotic, not clotting their blood, the risk of them dying from the second hit of a long surgery is far, far greater than the functional risk to the limb.
So it's a calculated trade-off.
It's a calculated trade-off that always, always favors survival.
So every decision is this kind of clinical calculus.
It is. The chapter boils it down to a triad of factors you're constantly weighing.
Right.
First, patient factors.
Yeah.
Their age, their other medical problems, their physiological state. Second, injury factors. How bad is it? Is it contaminated? Where is it? And third, surgeon factors.
Yeah.
What's my skill set? And critically, what resources do I have available?
And in the middle of all that has to be the patient's own goal.
Oh, absolutely. The idea of shared decision-making is non-negotiable. Optimal function for a professional athlete with a broken femur is totally different from optimal function for an 85-year-old who lives in a nursing home. You have to have that conversation.
Okay, great point to pause for our first check-in question.
Let's do it.
All right, imagine that patient from a car crash. They've had 10 units of blood. They're still hypotensive. They have an open tibial fracture, but it's splinted and not bleeding much.
Mm-hmm.
Right now, in this moment, what is your primary consideration for that tibia?
And the answer has to be the patient's overall stability.
Not cleaning the wound.
Not cleaning the wound, not rushing to surgery. The priority is resuscitation. You have to reverse the shock, the acidosis, the hypothermia. The tibia waits. If you were tempted to say anything else, just rewind the last few minutes and listen again to Life Before Limb and DCO. Survival is everything.
Okay, so once the patient is stable and we're in that secondary survey, our focus can finally shift completely to the injured limb.
Right, and diagnosis has to be systematic. You can't freelance here. It's a steer process. History, then examination, then investigations.
So let's start with history. The book emphasizes decoding the mechanism of injury, the MOI.
Because the mechanism is like a crystal ball. It predicts injury patterns. The amount of force involved tells you what to look for, often far away from the obvious injury.
Can you give us an example? Translate that energy into a prediction.
Sure, let's take a high-energy example. You hear from the paramedics that a passenger in a car crash hit the dashboard at 60 miles per hour. Immediately, your mind should be picturing that force transmitting up the leg. So you're thinking posterior hip dislocation, you're thinking femur fracture, but you're also thinking critically about deceleration injury to the chest, aortic rupture, blunt cardiac injury. The broken leg is just the most obvious sign of a massive systemic energy insult.
So the fracture is a symptom, not the whole disease.
Exactly. Now, contrast that with a low-energy injury. Someone falls onto an outstretched hand, a foosh injury.
Classic.
The force is concentrated, so you're thinking in a very linear way. Wrist fracture, scaphoid, elbow, maybe the shoulder or clavicle. The list of potential injuries is much, much smaller and more localized.
And to get all this vital information quickly, especially if the patient is confused or unconscious, we have the AMPLE mnemonic from ATLS.
Absolutely essential. A is for allergies, M is for medications.
And this one is huge.
Oh, it's critical. Are they on blood thinners? Steroids that will impair healing, immunosuppressants. P is past medical history. L is last meal, which tells you how safe it is to put them to sleep for surgery. And E is for events leading to the injury.
Which is where you get that collateral history from the paramedics about, how crumpled the car was, whether the patient was ejected.
All those details that paint a picture of the forces involved that you didn't get to see.
All right, moving on to the examination. We follow that classic system. Look, feel, move.
And you start with look. Before you even touch the patient, you're looking at the whole limb. Swelling, bruising, obvious deformity.
And there are some deformities that are just dead giveaways, right?
Absolutely. If you see a leg that is shortened and externally rotated, you have to suspect a proximal femur fracture until proven otherwise.
And the opposite.
A leg that's held flexed, adducted, and internally rotated, that's the classic sign of a posterior hip dislocation, which is a surgical emergency because of the risk to the blood supply of the femoral head.
And the book points out a really subtle but critical thing to look for on the skin. Even just a tiny graze over a fracture.
Yes, this is a pearl. That tiny little scrape, if it communicates with the fracture hematoma underneath, it instantly converts a closed fracture into an open fracture.
Which changes everything.
It changes your entire management. Now you're talking about urgent surgical washout, antibiotics, and it might even dictate what kind of metalwork you can use. You probably can't put a nail down that tibia until the skin is pristine.
Okay, next is feel.
You start gently, away from the injury, to build trust. You're feeling for tenderness, swelling, crepitus, that crunching feeling of bone ends rubbing together. And critically, you're checking for tenseness. But there's a huge caveat here for the lower leg.
What's that?
You cannot, and I repeat, cannot reliably feel for compartment syndrome in the deep posterior compartment of the leg. Palpation is just not accurate. If you suspect it, you have to measure the pressures directly.
Right. And then, of course, you're checking pulses, cap refill, temperature.
The full neurovascular assessment.
And then we get to move. And this is where the textbook warns about trick movements.
This is a golden nugget for students. Let's anchor this with the straight leg raise test.
Okay.
A patient is lying in bed, and their knee looks straight. You might think, great, the quad muscle is working, but gravity can do that. To prove the extensor mechanism is intact, the patient has to be able to actively lift their straight leg off the bed against gravity. If they can't do that, the mechanism is ruptured, even if the leg looks straight.
What's another common trick movement?
The Achilles tendon rupture. A patient with a complete rupture can often still weakly point their foot down using their toe flexor muscles.
So you could miss it.
You could easily miss it if you don't specifically test the power of the calf muscle, for example, with the Thompson squeeze test. High index of suspicion is everything.
Now, probably the most critical part of the exam, the neurovascular examination, or NVE. The book is really clear on this. Do not use summary terms.
I cannot emphasize this enough. Never, ever write neurovascularly intact in your notes.
Why not?
Because it's meaningless and it's lazy. You have to document specifically what muscles are working, what sensation they have in which nerve distribution, and you must do it before and after any intervention.
Before and after a reduction, before and after a cast.
Yes. Because if a nerve deficit appears after you've done something, that's a surgical emergency. It implies the nerve is now trapped or damaged by your maneuver, and you have to go and explore it.
Let's focus on the V in NVE, the vascular part, because this is where people can get falsely reassured.
Hugely important point. The presence of palpable pulses distally does not, I repeat, does not exclude a significant vascular injury.
How is that possible?
You can have what's called an intimal flap. The inner lining of the artery gets torn and flaps up. Blood can still get past it for a while, so you can feel a pulse. But over the next few hours, a clot can form on that flap and completely block the artery,
Leading to catastrophic limb ischemia.
Exactly. So if the mechanism of injury is high risk for an arterial injury, palpable pulses are nice, but they don't mean the patient is safe.
Okay, let's make this real. A 30-year-old snowboarder has a massive knee dislocation on the mountain. In the clinic, they reduce it, and they can feel pulses in the foot. The ER is busy. Is it safe to just admit this patient and wait for the ortho team in the morning?
Absolutely not. That patient has a limb-threatening emergency until proven otherwise.
Wow.
Up to a third of knee dislocations have an associated popliteal artery injury. Even with palpable pulses, you have to get an urgent CT angiogram to rule out one of those intimal tears.
And if you can't get one right away,
Then that patient needs to be in a high-dependency unit with hourly vascular checks, probably with a Doppler, for at least 24 to 48 hours. You are watching for that delayed thrombosis. It's a ticking time bomb.
and if there is a vascular injury with an open fracture, the surgical sequence is critical, isn't it?
It's non-negotiable. It's a rapid-fire sequence. First, you get temporary stability, usually an external fixator to get the bone out to length. Second, the vascular surgeon might put in a temporary shunt to get blood flowing downstream immediately. Third, you do your definitive bone fixation. And only then, fourth, do you do the final definitive artery repair or graft.
Why in that order? Why not just fix the artery first?
Because if you do a beautiful, delicate arterial repair and then start yanking on the bone to get it straight, you'll just rip your repair apart.
Right.
The scaffold, the skeleton, has to be stable in its final position before you can reconstruct the plumbing.
All right, moving on to investigations. X-rays are the workhorse, and the book hammers home the classic rule of twos.
Every student needs to have this tattooed on their brain. It's designed specifically to stop you from missing things.
So what are they?
Number 1, 2 views. You need 2 pictures taken at 90 degrees to each other, usually an AP and a lateral. A fracture can look perfectly fine on one view and be horribly displaced on the other.
The classic example being a posterior shoulder dislocation.
Exactly. It looks fine on the AP, but you get an axillary view and it's completely out. Number 2, 2 joints. The X-ray must include the joint above and the joint below the fracture.
Why is that?
Because high-energy injuries often cause associated injuries. A femur fracture might have a hip dislocation with it. A tibia fracture might have a subtle knee or ankle injury. You have to look.
Okay, what's number 3?
2 occasions. This is for those injuries where you have a high clinical suspicion, but the first X-ray is negative.
The scaphoid fracture.
The classic scaphoid. You treat them as if they have a fracture, put them in a cast, and bring them back in 10 to 14 days for another X-ray. By then, some bone resorption will have happened at the fracture line, making it visible.
And the last one.
Two sides. This is mainly for kids to compare the injured side to the normal side, especially around the growth plates, which can be confusing.
So following that rule helps you avoid that whole list of notoriously missed injuries in the textbook.
Right. And once you have your plain films, you might move on to advanced imaging. CT scan is king for bone.
What does it give you that X-ray doesn't?
It gives you incredible detail of the bony anatomy, especially for fractures that go into a joint. You can see it in 3D, really plan your surgery. And as we said, the CT angiogram is the go-to for looking at the arteries. The downside, of course, is the radiation dose.
And then there's MRI.
MRI is all about the soft tissues, ligaments, tendons, cartilage. And critically, in trauma, it can tell you about the blood supply to a piece of bone. Is it alive or is it dead? Which is vital for things like the scaphoid or the femoral neck.
But it's slow and not always available in an emergency.
Exactly. It's not usually a first-line acute test. And then you have things like nuclear medicine bone scans, which can be useful for picking up very subtle stress fractures, but again, not really for the acute trauma bay.
So to sum up diagnosis, a systematic approach is everything. AM/PLE history, a precise look, feel, move exam, meticulous NVE documentation, and strict adherence to the rule of twos.
You do that, and you'll minimize the chances of missing something critical.
Okay, so we've got the diagnosis. Now we need to classify the injury to create a sort of universal language, describe what we're dealing with.
And we always start with the soft tissues.
Why?
Because the state of the soft tissue envelope is the single biggest predictor of complications. Infection, healing problems, even limb loss. It all comes down to the soft tissues.
And the first big branch in the road is open versus closed.
Right, and an open fracture is any fracture where the fracture hematoma is in communication with the outside world through a break in the skin or, importantly, a mucous membrane.
So a jaw fracture that breaks through into the mouth is an open fracture.
It's an open fracture. A pelvic fracture that tears into the rectum is an open fracture. Any breach that lets bacteria in.
And for grading open fractures, the gold standard is the Castillo and Anderson classification.
It is. And it's all about energy. A type I is a low-energy injury. It's a small, clean wound, less than a centimeter.
A bone spike just poked through and went back in.
Exactly. A type 2, the wound is bigger than a centimeter, but there's no extensive crushing or soft tissue damage. But then you get to type 3.
And this is the big jump.
This is the high energy category. And the key teaching point is it's a type 3 based on the energy of the injury, regardless of the size of the skin wound.
So you could have a small puncture wound from a motorcycle accident, but the damage underneath is so severe that it's a type 3.
Absolutely. The massive stripping of the muscle off the bone, the contamination, that's what makes it a type 3. And then it's subclassified.
Right. A, B, and C.
ICA means that after you clean it all out, there's enough healthy tissue left to close the wound over the bone. IB means there isn't. The bone is exposed, and you're going to need a plastic surgeon to bring in a flap of muscle or skin to cover it.
And ILI?
IRI is the worst of the worst. It's a type 3 injury that also requires an arterial repair to save the limb. It carries the highest risk of amputation.
So that's the envelope. What about the wiring inside? The nerves?
For that, we use the setting classification. And the best way to understand this is to use the electric cable analogy. Think of a nerve as a complex electrical cable.
Okay.
The mildest injury is a neuropraxia. This is like a kink in the cable. The signal is temporarily blocked, maybe from pressure, but the cable itself, all the wires and the insulation are perfectly intact.
And prognosis.
Excellent. You relieve the pressure and it almost always recovers fully.
Okay, what's next?
Next is axonotmesis. In our analogy, this is where the internal copper wires are broken, but the outer rubber insulation, the sheath, is still intact.
Oh, so the conduit is still there.
The conduit is still there. The nerve will die back from the injury, but because that sheath is intact, it provides a perfect pathway for the nerve to regrow at about 1 millimeter a day. So recovery is possible, but it's slow.
And the most severe.
Neurotmesis, the whole cable is cut in half. Wires, insulation, everything.
And there's no chance of recovery without help.
0 chance without surgery to physically sew the two ends of the sheath back together. So the anchor concept here is the continuity of that nerve sheath. If it's intact, there's hope for regeneration. If it's cut, you need a surgeon.
All right, now for the bone itself. before we get into complex systems, we just need a clear way to describe the fracture.
And for displacement, the star mnemonic is really helpful. S is for shortening, T is for translation, or how much it's shifted sideways. A is for angulation, the bend, and R is for rotation.
And rotation is the sneaky one, isn't it?
It's the silent killer of a good outcome. You can't really see it well on an X-ray, but even a few degrees of rotation in a tibia can completely mess up a patient's gait and cause knee and ankle pain forever. You have to assess it clinically.
Now, for adult fractures, the universal language is the AO classification.
It is. It's incredibly detailed, maybe too detailed for day-to-day use. But it allows surgeons anywhere in the world to know exactly what fracture pattern they're talking about. It's based on which bone, which part of the bone, and how complex the fracture is, whether it's a simple break or shattered into the joint.
And for kids, it's all about the growth plate. So we use the Salter-Harris classification.
This is absolutely critical for anyone treating kids, because an injury to the growth plate, the physis, can stop the bone from growing correctly.
So what are the dangerous types?
Types I and II generally do well, but types 3 and 4 are the ones to worry about. They both involve a fracture line that goes into the joint surface and across the growth plate.
So it's a double whammy.
It's a double whammy. If you don't line them up perfectly, you'll get arthritis from the step in the joint, and you can get a bony bridge forming across the growth plate, which will stop growth on one side and lead to a crooked limb.
And that's why they often need surgery.
They almost always need open reduction and internal fixation to get that perfect alignment.
So, key takeaways for classification. Gustilo for the soft tissues tells you your infection risk. Seddon for the nerve tells you the recovery potential. And AO or Salter-Harris for the bone tells you what your goal for reduction needs to be.
That's a perfect summary.
Okay, so before we talk about how we treat fractures, we have to understand how they heal.
We have to, because everything we do as surgeons is just trying to create the right environment for biology to take over. And the key factor we can control is the mechanical stability at the fracture site.
Let's use the wound analogy from the book, because I think it makes this really clear. There are two ways a bone can heal.
Right. The first is direct or primary bone healing. This is the stitched wound.
Okay.
It only happens under very specific, unnatural conditions that we create with surgery. Absolute stability, no movement at all, and the bone ends pushed tightly together. When you do that, the bone heals directly across the gap without forming any callus. It's like normal bone remodeling.
And this is what you want for a fracture in a joint.
You have to have it. You don't want a big lump of callus forming inside a joint. It would block movement.
So what's the other pathway?
The other and much more common pathway is indirect or secondary bone healing. This is the scab and callus pathway.
The natural way.
This is how most fractures heal if you just put them in a cast. It happens when there's some micromotion, what we call relative stability. The body forms a hematoma, then soft tissue, then a big lump of cartilage or soft callus, which then slowly turns into hard bone.
So stability isn't just on or off, it's a spectrum.
It is. And this is where Perrin's strain theory is so important. Strain is basically how much the fraction gap deforms under load.
Okay.
The theory says that different tissues can only form in certain strain environments. If there's too much movement, too much strain, you only get fibrous tissue, it can't heal. If the strain is very, very low, less than 2%, you get that direct bone healing.
In the liver.
And in that sweet spot, with just a little bit of micromotion, that's what stimulates the cells to form that robust healing callus.
So the core principle is, a little bit of movement is good, it promotes healing. Too much movement is bad, it leads to non-union. And no movement is for joints only.
You've nailed it. Our whole choice of implant, a plate, a nail, a cast is all about trying to control the strain at the fracture site to get the type of healing we want.
And of course, beyond the mechanics, the biology has to be there. The blood supply.
Paramount. High-energy injuries that strip all the muscle and periosteum off the bone are a biological disaster. And then you have systemic factors.
Like what?
Smoking is public enemy number one. It's catastrophic for fracture healing. It can double or triple the healing time. Diabetes, poor nutrition, long-term use of NSAIDs, they all interfere with the healing cascade.
Let's quickly define the terminology here because it can be confusing. When is a fracture actually healed?
We use the term union when it's healed enough to withstand normal daily stresses without pain. Radiologically, you'll see callus bridging the gap.
And if it's slow?
That's delayed union. It's on its way, but it's taking longer than expected. Non-union is when the healing process has completely stopped, and it's not going to heal without some kind of new intervention.
And there are two types of non-union, which is a really important distinction.
Crucial,
Right.
because it tells you what the problem is. You have atrophic non-union. This is a biological problem. The bone ends are tapered and dead-looking on the X-ray. There's no callus. The biology has failed.
And run out of steam.
It's run out of steam. The treatment is to bring in new biology, usually a bone graft.
And the other type?
Hypertrophic non-union. This is a mechanical problem. The biology is going crazy, trying to heal. You see this massive fluffy callus on the X-ray, like an elephant's foot.
So the body is trying, but it can't succeed.
Exactly. There's too much movement. The strain is too high. The treatment isn't biological. It's mechanical. You have to make the fracture more stable, usually with a bigger plate or a nail. And then that big callus will finally turn into solid bone.
I love that. So atrophic is a problem of biology. Hypertrophic is a problem of stability.
That's the key takeaway.
Okay, so with all that biology understood, let's talk about treatment. The classic 4 pillars: reduce, hold, heal, and rehabilitate.
Right. And reduce means getting the bone fragments back into an acceptable position.
And the guiding question is, if I let this heal right here, will the patient have good function?
Exactly. And the answer is different depending on where the fracture is. For fractures that go into a joint intra-articular fractures, you need anatomical reduction. It has to be perfect. Less than 2 millimeters of a step in the joint surface, or they will get arthritis.
But for a fracture in the middle of a long bone?
For an extra-articular fracture, you just need mechanical alignment. You need to restore the length, the rotation, and the overall straightness of the limb. You don't have to have every little fragment perfectly lined up.
And how do we get that reduction?
We always try for closed reduction, first manipulating it without cutting the skin. But if that doesn't work, you have to do an open reduction. The caution there is not to strip away all the soft tissues and blood supply just to make the X-ray look pretty. You can win the battle, but lose the war.
So once it's reduced, we have to hold it. And this comes back to our stability choice.
Absolute versus relative. Absolute stability, no movement, is for those joint fractures. We use lag screws and compression plates to squeeze the fragments together. Relative stability-controlled micromotion is for the long bone shafts. We use things like bridge plates, nails, or external fixators to encourage that big, healthy callus.
Let's run through the tools in the toolbox then, starting with the most basic plaster casts.
Right. Plaster of Paris is great because it molds really well, but the critical point in an acute injury is that you never put on a full circumferential cast right away.
Because of swelling.
Because of swelling, you'll cause a compartment syndrome, so you use a back slab, which is open on one side, or you split the full cast down to the skin to allow it to expand.
Okay, what about traction?
Traction is still used, often temporarily, to hold a femur fracture out to length while you're waiting to go to the operating room. It's less common now as a definitive treatment because of the complications of being stuck in bed for weeks.
K-wires, the little pins.
Kirschner wires are great for small bones, like in the hand and wrist, or for temporarily holding fragments together during a bigger surgery. The big safety warning, though, is never to use them around the chest and shoulder.
Why not?
They have a notorious tendency to migrate, and there are case reports of them ending up in the heart or lungs.
Yikes. Okay, external fixators, the scaffolding on the outside.
These are so important for specific situations. They are the workhorse of damage control orthopedics. They're for the patient who is too sick for a big surgery. They're also for severe open fractures where the soft tissues are a mess and you need to let things calm down before you put metal inside.
But they're cumbersome, and the pin sites can get infected.
They are. They're often a bridge to a better definitive solution.
All right, plates and screws.
The go-to for joint fractures where you need that perfect anatomical reduction and absolute stability. But modern locking plates have changed the game.
How so?
Because the screws lock into the plate, the whole thing becomes a fixed angle construct. It means you can span a committed section of bone without having to compress it right down onto the periosteum. It essentially acts like an internal-external fixator, providing relative stability and preserving the blood supply.
And finally, the gold standard for long bone shafts.
Yeah.
Intramedullary nails.
Right. A nail down the middle of the bone. It's fantastic for load sharing, it's minimally invasive, and allows for that perfect relative stability to promote callus. The main risk, especially if you ream the canal, is fat embolism syndrome, where marrow fat gets forced into the bloodstream and goes to the lungs.
Which is another reason you might use an X-Fix first in a very sick patient.
Exactly.
And the last 2 pillars, heal and rehabilitate.
They go hand in hand. We know all the factors that slow healing. But rehabilitation has to start on day one, even before the bone is healed, to prevent stiffness and muscle wasting, that dreaded plaster disease.
So let's apply all these principles to a few specific regions of the body.
Great idea. For diaphyseal fractures, the middle of the long bones, it's all about mechanical alignment. So I am nailing is king for the femur and tibia.
But you mentioned the forearm is the big exception.
It is. The radius and ulna have to rotate around each other perfectly for you to turn your palm up and down. So even though they're shafts, you have to treat them like joint fractures. They need anatomical reduction and absolute stability with plates and screws.
Okay, let's talk about the scaphoid and the wrist, the one everyone's afraid of missing.
And for good reason, it's the blood supply anchor of orthopedics. The blood supply to the scaphoid bone comes in backwards, from the distal end to the proximal end.
So a fracture across the waist cuts off the blood supply to the top part.
Exactly. It leads to a high risk of a vascular necrosis. The bone dies. That's why we have such a low threshold to treat snuffbox tenderness as a fracture, even with a negative X-ray. A displaced fracture needs a screw to compress it and try to restore that blood flow.
What about the humeral shaft? The big risk there is the radial nerve.
Right. The radial nerve wraps right around the bone. It gets bruised or stretched commonly. But the management is nuanced. If the nerve palsy is there right at the time of injury, a primary palsy, we usually just watch it. Most of them are neuropraxias and will get better on their own.
Why?
But if the palsy happens after you reduce the fracture or put on a secondary palsy, that's a red flag. It means the nerve is probably now trapped in the fracture site and you need to go to the OR to explore it and get it out.
So primary palsy you watch, secondary palsy you explore.
That's the rule of thumb.
Let's finish with the proximal femur, hip fractures.
It's all about the blood supply again, just like the scaphoid. The key is whether the fracture is inside the joint capsule intracapsular or outside extracapsular.
Intracapsular is the bad one for blood supply.
Right. A displaced intracapsular fracture in an elderly patient has such a high risk of the femoral head dying that we usually don't even try to fix it. We just replace it. A hip replacement. In a young person, you have to try and fix it to save their own hip, but you warn them about the risk of AVN.
And extracapsular fracture.
The blood supply is great. It's purely a mechanical problem of getting it stable, usually with a screw and plate device or an intramedullary nail.
Okay, let's wrap this up with a final case study that brings in that shared decision-making. A 35-year-old mechanic, very active, breaks his clavicle. It's displaced, it's comminuted, and it's shortened by 2.5 centimeters.
Okay.
You could treat it without surgery, but the data says there's maybe a 35% risk of it not healing, and that shortening will affect his shoulder function. Or you could operate, which has a higher chance of healing and restoring length, but it has surgical risks. How do you have that conversation?
You have it with the evidence. You lay out the numbers just as you did. You say, look, for your job, you need predictable, strong overhead function. Without surgery, there's a real chance you won't get that. With surgery, the chance of a good functional outcome is much higher, but we have to accept the small risks of infection or needing another operation down the line.
So it's about his specific functional demands.
It's all about his demands. For this mechanic, whose livelihood depends on his shoulder, the balance almost certainly tips towards surgery. But it has to be his decision, weighing the risk of disability against the risk of the operation.
This has been an incredibly detailed journey through a huge topic. If you had to boil it all down, what are the final big picture takeaways?
I think it's this. Trauma management is a hierarchy. It's always life before limb. And our treatment is about using mechanics to create the right biological environment, absolute stability for joints, relative stability for shafts.
And none of it works without that systematic initial assessment.
You can't skip steps. That's how you miss things. The AMPO-Lee history, the detailed NVE, the rule of twos, that's your safety net.
We started by talking about Achilles and how a single vulnerability can be someone's downfall. The book highlights how it's often the small, subtle injuries that get missed and lead to that lifelong impairment.
That's so true.
So, as a final provocative thought for our listeners, besides the scaphoid or a knee dislocation, if you had to pick one other notorious, often missed injury that looks subtle but can cause devastating long-term disability, what should we all be paranoid about?
That's a great question. For me, it has to be the Lisfranc injury.
A midfoot sprain.
It looks like a midfoot sprain. It's a tarsometatarsal fracture dislocation. It's so easy to dismiss. But if you miss the instability in that joint, the patient develops a collapsed arthritic foot. and it is a nightmare of chronic pain and disability.
So what's the tell?
You have to look really, really carefully at the alignment on the foot x-rays. Any subtle widening between the first and second metatarsals or a little fleck of bone in that space is a Lisfranc injury until proven otherwise, and it's an orthopedic emergency.
A perfect final warning. The danger really does lurk in the subtle details. Thank you so much for joining us for this deep dive. We really hope you'll now go to Chapter 32 in Baily and Love and use these concepts to solidify your understanding.
Absolutely. Until next time, stay systematic and never stop being curious.